Good afternoon, everyone. Welcome to this special session highlighting 3 new drug approvals for treatment of metastatic breast cancer. My name is Laleh Amiri-Kordestani. I'm a hematologist-oncologist and direct the Division of Oncology 1 at FDA. I'm honored to co-moderate this session with Dr. Piccart, and we have 3 presentations done by 3 FDA staff and followed by a panel discussion. Now I would like actually the speakers and panel actually introduce yourselves briefly, and then we can follow with the presentations. After each of the presentations, please actually submit your questions. We'll take questions. And after the panel discussion, also happy to take more questions. Hopefully, we'll have a good discussion.
Do I start? Yeah. Good afternoon, everybody. So my name is Martine Piccart. I am a medical oncologist, scientific director at the Jules Bordet Cancer Institute in Brussels, Belgium, past chair of the Breast International Group.
Hi, good afternoon, everyone. My name is Preeti Narayan. I'm a medical oncologist and clinical team lead at the FDA on the breast and gynecologic malignancies team.
Good afternoon. My name is Mirat, Shah, and I'm a medical oncologist at FDA specializing in breast and gynecologic malignancies.
Good afternoon. My name is Christy, Osgood, and I am a pediatric oncologist working in the Division of Oncology 1, which specializes in breast and gynecologic malignancies.
Hello, my name is Flora Mulkey. I'm a biostatistician at FDA CEDAR, and I support, again, DO1, which does breast and gynecological malignancies.
Hello, good afternoon. My name is Valia Karanja. I am a medical oncologist. I represent industry in the panel. And I used to be a physician scientist with a basic research laboratory, and as of 10 years ago, transitioned to industry, and until very recently, I led the breast cancer program at Merck.
Hi, everyone. My name is Janice Cowden, and I am a patient advocate living with metastatic triple-negative breast cancer for 7.5 years. Pleased to be here.
Yes, this does need an applause. My name is Virginia Kakamani. I'm from UT Health in San Antonio. I represent the academic physicians, and I welcome everybody to SABCS first session. It's great to see a full house.
So it's now my pleasure to introduce the first speaker, Dr. Narayan from the FDA, who is going to present a quite fascinating drug, Trastuzumab deruxtecan.
Hi, good afternoon, everyone. My name is Preeti Narayan, and I'm a medical oncologist at the FDA and the breast and gynecological malignancies team. Today, I will be presenting on the FDA approval of Trastuzumab deruxtecan, or TDXD, for the treatment of HER2-low advanced or metastatic breast cancer. These are my disclosures. These are the topics I'll be discussing today. First, I will provide some background on TDXD, followed by the pivotal trial design and results of DESTINY-Breast04 used for this approval, and then conclude with regulatory insights taken into consideration during this review. So to start off as a little bit of background, TDXD is an antibody-drug conjugate consisting of an anti-HER2 monoclonal antibody that is linked to a topoisomerase I payload. The current FDA approvals for TDXD include unresectable or metastatic HER2-positive breast cancer after prior HER2-based therapy, as well as advanced or metastatic gastric or JG adenocarcinoma after a prior trastuzumab-based regimen, and an accelerated approval for unresectable or metastatic non-small cell lung cancer with activating HER2 mutations. This approval for TDXD is for adult patients with unresectable or metastatic HER2-low, that's IHC 1+ or IHC 2+ ISH negative breast cancer, as determined by an FDA-approved test, who have received a prior chemotherapy in the metastatic setting or developed disease recurrence during or within 6 months of completing adjuvant chemotherapy. The dose approved for HER2-low breast cancer is 5.4 milligrams per kilogram intravenously once every 3 weeks. Of note, all other approved indications are also at this dose, except for the gastric JEG indication, which is at 6.4 milligrams per kilogram. Prior to this approval, HER2-low breast cancer was treated similarly to HER2-negative breast cancer, where therapy was guided by hormone receptor status. Although HER2-targeted therapies have significantly improved outcomes for patients with HER2-positive breast cancer, historically, HER2-targeted therapies have not been shown to be effective for tumors with low HER2 expression. In addition, the HER2-low subgroup constitutes a heterogeneous population that includes both hormone receptor-positive breast cancer and triple-negative breast cancer, which is also hormone receptor negative. Specifically looking at available therapies at the time of this review, therapies for hormone receptor breast cancer included endocrine therapy plus a CDK4/6 inhibitor as the preferred first-line therapy. Following this, therapies may include endocrine therapy alone, endocrine therapy with a targeted agent, and/or chemotherapy. For triple-negative breast cancer, therapies may include pembrolizumab plus chemotherapy for tumors that are CPS greater than or equal to 10, sacituzumab, or chemotherapies. So, how does HER2-low fit into the consideration of HER2 status? For tumors defined as HER2-negative per ASCO-CAP guidelines, there is a subset that have low HER2 expression, again, either IHC 1+ or 2+ ISH negative or non-amplified, that comprise an estimated 50 to 60% of what was considered HER2-negative tumors, including both hormone receptor-positive and triple-negative breast cancer. As I've noted previously, this subset of HER2-low expression was considered HER2-negative and was not eligible for HER2-directed therapies prior to this approval. DESTINY-Breast04 was the pivotal trial used in the review of this approval. Patients were enrolled with centrally confirmed HER2-low breast cancer who had previously received 1 or 2 lines of chemotherapy in the metastatic setting. In addition, patients with hormone receptor-positive breast cancer were required to have endocrine refractory disease. HER2-low, again, was defined, as I previously described, by ASCO-CAP guidelines. Patients were randomized 2-to-1 to TDXD or treatment of physician's choice therapy, which included capecitabine, eribulin, gemcitabine, paclitaxel, or nab-paclitaxel. The primary endpoint was progression-free survival by blinded independent central review in patients with hormone receptor-positive HER2-low breast cancer. Key secondary endpoints were progression-free survival for all patients and overall survival for the hormone receptor-positive and all patients on study. The majority, or 88% of patients enrolled, had tumors that were hormone receptor-positive. In addition, 70% of hormone receptor-positive tumors enrolled in the trial were treated with a prior CDK4/6 inhibitor. Now moving on to the PFS results from this trial. At the time of data cutoff, the primary endpoint of PFS by blinded independent central review in the HR-positive cohort showed a statistically significant and clinically meaningful improvement with an estimated PFS hazard ratio of 0.51. The observed median PFS was 10.1 months in the TDXD arm and 5.4 months in the physician's choice arm. PFS in the ITT population, which was a key secondary endpoint, was also met. The stratified hazard ratio was 0.5, and median PFS was 9.9 months in the TDXD arm and 5.1 months in the physician's choice arm. Here you can see the Kaplan-Meier curves for the hormone receptor-positive and ITT populations respectively that show separations of the curves throughout. Now moving on to the overall survival results from this trial. As the analysis of PFS were significant in both the HR-positive cohort and the ITT population, the first interim analysis of overall survival was performed at the time of data cutoff. In the HR-positive cohort, the hazard ratio for overall survival was 0.64, which crossed the pre-specified IA efficacy stopping boundary. Median OS was 23.9 months for TDXD and 17.5 months for physician's choice. In the overall population, the hazard ratio was 0.64 that also crossed the pre-specified interim analysis efficacy boundary. The median OS was 23.4 months for the TDXD arm and 16.8 months for the overall population. Again, the corresponding Kaplan-Meier curves for OS in the hormone receptor and ITT populations show the separation of these curves, similar to the PFS results. Touching upon subgroup analysis, major subgroups that were analyzed as part of this review in HER2-low breast cancer included the triple-negative breast cohort and tumors with rapid progression, as the protocol had allowed enrollment of these populations. The TNBC cohort, although a relatively small sample size, showed consistent PFS and OS results in an exploratory analysis to the PFS and OS results in the hormone receptor positive and ITT populations. Similarly, an exploratory analysis in the population of tumors that experienced rapid progression during or within 6 months of neoadjuvant or adjuvant therapy showed benefit consistent with the overall study results. Therefore, it was reasonable to include these populations in the indication. For safety, the FDA analysis of safety in the DESTINY-Breast04 trial did not identify any new safety signals beyond those already known and labeled for TDXD. Serious adverse events occurring in more than 1% of patients included ILD, or interstitial lung disease, and pneumonitis, pneumonia, shortness of breath, sepsis, as well as GI and hematologic toxicities that are noted here. Interstitial lung disease and pneumonitis, which is an adverse event of special interest, can cause severe and life-threatening toxicity. This occurred in 14% in those receiving TDXD versus 0.6% in the physician's choice arm, and remains a boxed warning and labeling to emphasize the importance of close monitoring for symptoms that could indicate the development of these lung toxicities. In addition, left ventricular dysfunction remains a warning and precaution in labeling given the mechanism of action of TDXD, and occurred in 5% versus 0% for the TPC arm. So, to summarize some of the regulatory decision-making for this approval, DESTINY-Breast04 met its primary endpoint in the hormone receptor-positive population. In addition, all key secondary endpoints were met, including a statistically significant and clinically meaningful benefit for PFS in the ITT or overall population, OS in the hormone receptor-positive and overall population, and no new safety signals, as I noted, were noted in the HER2-low setting beyond those already known for TDXD. In addition, consistent benefit was also observed across the pre-specified subgroups in the study, including the triple-negative breast cancer cohort and tumors with rapid progression. So this approval of TDXD for HER2-low unresectable or metastatic breast cancer on August 5, 2022 represented the first FDA-approved treatment option specifically for this newly defined subset of low HER2 expression, previously considered HER2 negative. Given the significant PFS and OS benefits seen, this indication was granted regular approval for adults with HER2-low unresectable or metastatic breast cancer. As the landscape for HER2 continues to rapidly change now with the inclusion of therapy for a HER2-low population, sequencing available therapies will need further data in the future. And just to add here, this is for more detail on this approval and the FDA approval summary. You can find this in the Journal of Clinical Oncology, which I've included here with a link. Finally, I'd like to thank the conference organizers and the opportunity to present this FDA approval and our thinking regarding recent FDA approvals in breast cancer. And I'd also like to thank all our FDA colleagues and others who are involved in this presentation. And I look forward to the continued conversation. Thank you.
So this presentation is open for questions, either online or from the audience. I must say that we can hardly see the room. Well,
Dr. Piccart, can I ask the first question? So you mentioned the fact that the triple negative subset was a pretty small subset. I think the data that we had seen was 58 patients. You guys had 63. What decision-making went there in approving it, especially given the 10 to 15% ILD rate that we see throughout all of the clinical trials with TDXD?
That's a great question. I mean, yeah, I agree. It was a very small cohort, and I think the plan initially when that trial was designed was to try to represent the incidence in the population of HER2 low patients. Always when we see subgroups like that, even though if they're exploratory, it's important to do an analysis and to be looking at the results. And in this case specifically, as I noted, the results in PFS, OS, and overall response rate were very consistent with the overall responses in the whole trial. And so even though, again, it was an exploratory small subgroup, based on discussion, it made sense to include this in the final indication because it seemed like these patients, this patient population was driving benefits. So that was why it was included in the final population. But I agree, it's always good when we can have as many patients in a subgroup as possible to have more certainty around a result.
We have a question there.
Yeah, hi, Martine. Lisa Carey, University of North Carolina. A quick question about first off, this is a great idea to do this kind of a panel and to get the FDA's insights. One question I had specifically about the TDXD approval was, when you guys were addressing this, did the clinical validity of the biomarker, the companion diagnostic, come up in the conversation? I understand it is the population was tested, but I think there's some real questions about how we approach these kinds of issues.
Maybe I can take this question because we actually don't have reviewers from CDRH with us, but during their drug development, actually, they discussed their device several times with the CDRH colleagues, and we were present, so that was addressed. And actually, as you saw that, the approval actually also was for the device, so the clinical validity was actually approved by the CDRH for the selection of patients in the United States.
I read the paper by Dr. Narayan in JCO carefully, and you are recognizing the subjectivity that might be associated to HER2 low evaluation. And there is a sentence written there which is interesting. You say that if the positivity of the cancer cells is between 5 and 20 or 20%, you would advocate a second pathologist reading. But how is that feasible in real life? Because, in my country, there are fewer and fewer pathologists around. So you think that this will be implemented? On the other hand, if TDXD works very well in HER2 zero patients, this issue might altogether disappear. But we have to see.
I agree. I think this is an area that there's still a lot of data being gathered, and I think depending on how people are able to test right now, I think we had confidence, at least with the companion diagnostic that was approved, that it was selecting the current patient population, and certainly as more data is available, we can always take that into consideration.
I had another question to the FDA. The blinded independent central review, how important do you think that is? Because there have been comparisons between these blinded evaluation and PFS evaluated by investigators, and many publications indicate that they are very similar in terms of the results. So do you think it's important?
I'll ask our statistician to comment on this.
Right. So, we do feel at the FDA, we do like to see blinded independent central review of results because there is, a lot of times there can be a chance of having some assessment bias. And we like to see, and we generally do compare, we do many analyses to see how they differ, what type of discrepancies there may be, and we use all of that in determination. I think especially with single-arm trials, we also like to have that additional confidence from having an independent central review of the data.
I think we can move on to our next presentation. Oh, I see there is another. Please go ahead.
Hi, my name is Julie Fu from MGH Emerson in Concord, Massachusetts. I have a few patients on HER2, and they describe this mental fog, emotional lability, and I know we focus on, interstitial lung disease, and I was just wondering if that was a common side effect that you saw on your study. Thank you.
So I will say in the review of these trial results that didn't come up as a major side effect, but certainly one thing I'll say generally is we're always interested in the post-marketing reports, and so as we continue to get more data from the real-world use and side effects that may have not been seen in the trials, certainly that's something we always encourage submission of a MedWatch form so that we can keep an eye on these things, and should enough data for a signal come up, we can always discuss internally and see how that needs to be, if that needs an updating and labeling.
Okay, so now we can move on to the next presentation. Dr. Shah will present Elacestrant's approval.
Good afternoon. Again, my name is Mirat Shah, and today I will be presenting FDA's approval of Elacestrant for the treatment of patients with ER-positive, HER2-negative, ESR1-mutated advanced or metastatic breast cancer. These are my disclosures. And during my presentation today, first I'll provide some background on Elacestrant as well as the disease setting. I will then review the design of the trial, which led to Elacestrant's approval. I will then present the trial results, and then finally I will discuss FDA's thinking and decision-making regarding this approval. So Elacestrant is an oral estrogen receptor antagonist, and the approved indication is for the treatment of postmenopausal women and men with ER-positive, HER2-negative, ESR1-mutated, advanced or metastatic breast cancer with disease progression following at least one line of endocrine therapy. Throughout the presentation, I'll discuss why this is the approved indication, and particularly the restriction of the indication to patients with ESR1 mutations detected only. The recommended dosage for Elacestrant is shown on the slide. In terms of the disease setting, for patients in the US, the preferred first-line treatment is generally endocrine therapy with a CDK4/6 inhibitor. And again, this is for patients with ER-positive, HER2-negative, advanced or metastatic breast cancer. Following first-line treatment and subsequent lines of therapy, patients may receive endocrine treatment alone, endocrine treatment with a targeted agent, or chemotherapies and antibody-drug conjugates. And just an additional note that tumor mutations in ESR1 are a common cause of acquired resistance to endocrine treatment. This is the design of the EMERALD trial, or study RAD 19-01-308, which led to the approval of Elacestrant. This trial enrolled postmenopausal women or men with ER-positive, HER2-negative, advanced or metastatic breast cancer. To be eligible for this trial, patients had to have received 1 or 2 prior lines of endocrine therapy, and one of those lines had to contain a CDK4/6 inhibitor. Just an additional thing to note, this is the first trial leading to an FDA approval in which all patients had received prior treatment with a CDK4/6 inhibitor. The stratification factors for randomization were whether or not an ESR1 mutation or mutations were detected, whether patients had received prior treatment with fulvestrant, and whether or not patients had visceral metastases. Patients were randomized 1-to-1 to receive either Elacestrant or investigators' choice of endocrine therapy. Those choices were an aromatase inhibitor or fulvestrant. The primary endpoint was progression-free survival, or PFS, assessed by blinded independent central review, tested both in the subgroup of patients with ESR1 mutations as well as the entire trial population. Overall survival, again, both in the subgroup of patients with ESR1 mutations and in the entire trial population, was a key secondary endpoint with alpha allocation. This slide shows the progression-free survival results for the EMERALD trial. To orient everybody to the slide a bit, the entire trial population is shown in the leftmost columns. The subgroup of patients with ESR1 mutations or the ESR1 mut subgroup is shown in the center columns, and the subgroup of patients without detectable ESR1 mutations or the ESR1 mut not detected subgroup is shown in the rightmost columns. Just a reminder that PFS was formally tested in both the entire trial population as well as the ESR1 mut subgroup. PFS was not formally tested in the subgroup of patients without detectable ESR1 mutations, and these results are exploratory. In terms of the median PFS in the entire trial population, so it's 2.8 months on the Elacestrant arm and 1.9 months on the control arm. And the ESR1 with a hazard ratio, of 0.70 and the 95% confidence interval shown on the slide. And the subgroup of patients with ESR1 mutations detected, the median PFS was 3.8 months compared to 1.9 months with a hazard ratio of 0.55 and the 95% confidence interval shown on the slide. And then the ESR1 mut not detected subgroup, the median PFS was 1.9 months compared to 2.0 months with a hazard ratio of 0.86 and the 95% confidence interval shown on the slide. I'll continue to discuss the PFS results on the next slide. Just one more thing to note is that the PFS on the control arm was short in both the entire trial population as well as these key subgroups. And I'll revisit this in the presentation too. This slide shows the Kaplan-Meier curves for PFS in the entire trial population, the ESR1 mut subgroup, and in the ESR1 mut not detected subgroup. You can see that the curves stay apart in the entire trial population as well as in the ESR1 mut subgroup and are much closer together in the ESR1 mut not detected subgroup. In addition to the primary PFS analyses, FDA also conducted additional sensitivity analyses looking at PFS. In these additional sensitivity analyses, the Kaplan-Meier curves in the ESR1 mut subgroup remained apart. However, in the ESR1 mut not detected subgroup, these curves were essentially superimposable or overlapping. It was these primary PFS results as well as the additional looks through the sensitivity analyses which led FDA to conclude that the PFS improvement in the entire trial population was primarily attributable to patients with ESR1 mutations. This slide shows the overall survival results from the EMERALD trial, again with the entire trial population on the left, the ESR1 mut subgroup in the center, and the ESR1 mut not detected subgroup in the rightmost columns. Overall survival was formally tested in both the entire trial population as well as the ESR1 mut subgroup, and then the results in the ESR1 mut not detected subgroup again are exploratory. The OS endpoint was not met in either the entire trial population or in the ESR1 mut subgroup. Hazard ratio of 0.91 in the entire trial population and 0.90 in the ESR1 mut subgroup, indicating that there was no potential detriment in OS. In the ESR1 mut not detected subgroup, the overall survival hazard ratio of 0.92 was similar to the overall trial population, as well as the ESR1 mut subgroup. However, there was asymmetric withdrawal of consent specifically in this subgroup, which led to more uncertainty in the OS estimate in this subgroup relative to the rest of the trial population. This slide shows the overall survival Kaplan-Meier curves in the entire trial population, the ESR1 mut subgroup, and the ESR1 mut not detected subgroup. Regarding safety for the EMERALD trial, patients who received Elacestrant are shown in the center, are represented in the center column, and patients who received standard of care are shown in the right column. This slide shows both the all-grade treatment-emergent adverse events on the EMERALD trial as well as the most common laboratory abnormalities. In terms of the safety profile, Elacestrant was associated with increased GI toxicity relative to standard of care, particularly increased nausea and vomiting. In terms of laboratory abnormalities, Elacestrant was associated with an increased risk of dyslipidemia compared to standard of care treatments, and dyslipidemia was labeled under warnings in the Elacestrant label. Before I move on to FDA's interpretation of the EMERALD trial results, I did want to review two common trial designs in oncology, a replacement design and an add-on design, and also review how FDA considers risk-benefit interpretation in the context of the trial design. So Emerald had a replacement design, which is also often called a head-to-head design, in which the investigational agent, in this example, drug A, is replacing or being compared directly to the standard of care treatment, in this case, drug B. In this type of trial design, even a relatively modest improvement in an efficacy endpoint like PFS can still support an approval because this improvement with the investigational agent, which might be modest, is in addition to the known benefit of the active standard therapy. I think this is a little bit confusing, and so I'm going to explain this one more time in a slightly different way, and we can also discuss it during the discussion portion. So for example, in the slide I'm showing, if there is a median PFS of 4 months with drug B, and then the investigational agent, drug A, has an improvement in PFS of 2 months, the PFS benefit of drug A is not just those 2 months, but the 2 months added to the 4 months from drug B, so it's really 6 months. And again, we can discuss this further in the presentation, in the discussion portion. In contrast to a replacement design, another common trial design in oncology is an add-on design. In this type of trial design, the investigational agent, drug A, is added to the standard of care treatment, drug B, and compared to standard of care treatment alone, in this case, drug B. In this type of trial design, the improvement in the efficacy endpoint needs to be large enough to outweigh the added toxicity of adding drug A to drug B. My colleague, Dr. Christy Osgood, will discuss this type of trial design further in her presentation. So with that, I'll discuss FDA's decision-making regarding the approval of Elacestrant. So the indication was restricted to patients with ESR1 mutations. The trial met its PFS endpoint in both the ESR1 mute subgroup as well as the entire trial population with no potential OS detriment. However, as I reviewed on prior slides, FDA concluded that the PFS improvement in the entire trial population was primarily attributable to the patients in the ESR1 mute subgroup. And as I reviewed on the prior slide, in a replacement design trial, even a modest PFS improvement may support approval. In contrast, FDA concluded that the benefit-risk assessment in patients without ESR1 mutations was not favorable. The reason for this is that there is a marginally positive PFS trend with really uncertain clinical relevance in the setting of a short PFS on the control arm. There is also uncertainty in the OS estimate specific to the subgroup. In addition, during this review, there was emerging external data from other oral estrogen receptor antagonists suggesting that there might be greater activity of these agents in the presence of a tumor ESR1 mutation. In terms of safety, elacestrant was associated with increased GI toxicity as well as an increased risk of dyslipidemia. FDA concluded that in the patients with ESR1 mutations, the safety profile was justifiable because there was evidence that those patients were experiencing clinical benefit. However, in the patients without ESR1 mutations, FDA felt that the safety profile was not justifiable because clinical benefit was uncertain. Before I conclude, I wanted to make one more comment on how FDA interprets subgroups. This also came up in Dr. Narayan's presentation. So some of our conclusions of the Emerald trial, of course, relied on patients with ESR1 mutations, and that was a subgroup that was formally tested. However, our conclusions also relied on interpretation of patients, of the subgroup of patients without ESR1 mutations, and those were exploratory. And so, of course, exploratory subgroups, analyses of exploratory subgroups must be interpreted with caution. Some of the factors that can increase confidence in the results include if there's a biologic rationale for the results seen, and particularly if there are consistent findings in other trials in the same disease setting with similar products. Similar findings across trials decreases the probability that a finding in one trial is due to chance. In addition, if the subgroup is included as a stratification factor, as was the case in this trial, randomization may be preserved. And also, if the subgroup has a larger sample size, in this case, the ESR1 mute not detected subgroup made up about half of the trial population, that can also increase confidence in the results. So in conclusion, elacestrant received traditional approval for the treatment of patients with ER-positive, HER2-negative, ESR1 mutated advanced or metastatic breast cancer. The indication was restricted to the ESR1 mute subgroup due to differential benefit risk in patients with and without detectable ESR1 mutations. And finally, this is the first approval of an oral estrogen receptor antagonist, specifically for patients with ESR1 mutations. There are more details of our decision-making regarding this approval in our review, which is available at Drugs at FDA. With that, I'd like to thank the conference organizers for inviting me to be part of this session and to present this approval. I'd also like to thank all of my colleagues at FDA who had input on this presentation. And thank you all very much for your attention.
Thanks, Dr. Shah. So if there are any questions, we can take a couple of questions. Yes.
Thank you very much for Elacestrant. Now, the speaker, they didn't tell us how they test for ESR1 mutation. Now, given the fact it has been used, the Guardian 360. And now, if you are in the clinic, not on a presentation, you are asking for Guardian 360, and it becomes negative for ESR1 mutation. So this is not accurate, because we know the Guardian 360, they are looking for the ESR mutation between the 310 amino acid and 560 amino acid. There is another 100 amino acid that has not been covered by 360. So basically, we have a lot of patients, we are missing ESR1 mutation. So if you are in somewhere, maybe you need to do a tissue, maybe you have to look for more gene, but the Guardian 360 is not enough to give Elacestrant. This is question number one. My question number two, do you know when the third can be work as a SERM? You give the patient Elacestrant, but inside the body it is working as tamoxifen. Anybody knows? The third question, which is in the presentation, increasing the cholesterol level. We know in any patient breast cancer today who has dyslipidemia, and you are giving whatever the hormone, they have poor prognosis. And in fact, you know, in Emerald trial, I don't think that anybody looked for dyslipidemia and survival, because the side effect of Elacestrant in the clinic you have to look at is dyslipidemia. So this is question about testing, question about working, and the question about the side effect. Thank you very much.
I appreciate. Can you also introduce yourself, please, before asking questions in the audience? Thank you.
I can start and at least answer one or two of your questions and then see what my panel members have to add. So I think your first question was regarding detection of specific ESR1 mutations. I think that's a great question. Unfortunately, when we are presented with trial results at FDA, we have to make our interpretation based on how the trial was conducted and including how mutations were detected in that particular trial. I think your question is incredibly important, and it's really why these things should be assessed in the trial design setting, and particularly issues with blood versus tissue testing should really be addressed in the design phase and also the conduct of the trial. Regarding your point about dyslipidemia, I agree. I think that's incredibly important to consider, what are the unintended consequences of taking a particular therapy. In this case, we were also concerned about the dyslipidemia. That's why we put it as a warning in the Elacestrant labeling. And particularly in settings where patients might be on this therapy for longer, they're experiencing particularly good response with this therapy, increasingly important to consider, what might be the effects, the unintended effects like dyslipidemia.
Yeah, adding to this, thank you very much for this. Adding to this, if you go for the same patient and you do a digital droplet PCR, you're looking for 5 hotspot mutation. You cannot see it on the Guardian 360, but you can see it on ddBCR. And this is the confusion came for the personalized medicine, how to select the patient, how to get the patient. Anyway, I am from the Kingdom of Saudi Arabia. My name is Dr. Tahir Al-Tuwaijiri. I am senior medical oncologist and from King Faisal Hospital, and thank you very much. Thank you.
I appreciate that. Thank you. I see there is one more question, maybe from the other microphone. please.
Thank you. Thank you.
Appreciate if you first introduce yourself.
Yes,
Thank
sure.
you.
Bill Sykoff from Rhode Island. I actually also have two questions. I apologize for that in advance. My first question is, given that outcomes on either arm of the EMERALD study were very poor in patients who had progressed in less than 12 months on their prior endocrine therapy with CDK4/6 inhibitor, should we bother to test those rapidly progressing patients for ESR1 mutation? That's my first question. My second question is, I've had a number of cases where patients in my mind are clearly progressing, and yet I send the circulating tumor DNA analysis and I'm told that there is not an elevated circulating tumor fraction. So ESR1 was not detected, but I wonder if that's a test I should repeat, a few months later if the patient continues to progress on whatever other treatment I give them, or if I should try when I can to get a tissue sample to test for the ESR1 mutation.
I think those are great questions. I'm going to answer from my perspective as a regulator, but I would actually be very interested to hear from other members on the panel who are also in the clinic. Regarding your first question, I agree. I think I pointed out that this trial is the first trial leading to an FDA approval, which occurred entirely in the post-CDK4/6 inhibitor setting, and I think we, as a community, really need to consider what is the next best treatment, and I'm hoping to gain insight on that question actually at this conference over the next few days. I think that's really the key question to be asking. And then regarding your question with the ctDNA testing, I think, again, this points to issues with ctDNA versus tissue testing, and I don't want to speak, outside of my scope as a regulator, so would invite other people to provide perspectives, but I think it's hard, particularly this is an acquired resistance mutation. You can't use tumor tissue that you might already have from, a previous line of therapy or from the early setting, and it's a whole layer of complexity regarding detecting this mutation that might not exist with other biomarkers. But if anybody on the panel has anything to add.
I guess I'll answer the medical oncology part. And Bill, obviously, when we have two arms that are not doing extremely well, you're trying to find subsets, and maybe one of the subsets is going to do a little bit better than the other subset. And I think that's where we as medical oncologists tweak things to try to find the right patients to treat with any of these drugs, especially Elacestrant. Because we have to find the endocrine sensitive patients. Not every single patient is going to benefit from this treatment. So that's how at least I will approach it in clinic.
Thank you. Thank you.
Hi, good afternoon. Shweta Jain from CGen. Thank you so much for explaining in detail the considerations that agency had. One question that I have is, in this situation where the PFS benefit was modest, agency had mentioned that other reviews that showed some positive benefit in targeting the ESR mutated population supported the decision making. Hypothetically speaking, if other technologies had shown maybe a negative effect, would that weigh into the agency decision making?
Yeah, so to clarify, that was public data regarding the other products, not data internal to FDA. And so I think it's a great question, and I think it's kind of the totality of the data that exists from the biologic rationale, how the biomarker positive and biomarker negative patient populations were accounted for within the specific trial design, and then additional emerging external data that might support that there is a biologic rationale for differential benefit risk between a biomarker positive and biomarker negative subgroup. So I wouldn't say that one piece of that puzzle being a different way might lead to a different conclusion. It's really the totality of the data.
Thank you.
Can I also ask one thing about these, drug A versus drug B trial, and you have now an alternative which has been on the market for over 20 years in fulvestrant, which is an intramuscular injection, and now you have an oral medication which is in the non-mutated patient population at least as effective. Is there any thought from the FDA to actually give patients, and I want to ask our advocates' perspective as well, is there any thought in giving patients the option of having an oral agent instead of an IM with, again, similar efficacy results?
So I think that's a complicated question, and perhaps I'll ask Flora Mulkey also to comment from a statistical perspective. But I think, the phrase "at least as effective," this wasn't designed to be a non-inferiority trial, and perhaps Flora wants to comment a little bit more on that. So I don't think we've proven that it's at least as effective. Definitely we considered that it would be perhaps good for patients to have an option for oral therapy, certainly, but that had to also be considered with the increased risks of GI toxicity associated with the oral product relative to an IM product. But Flora, I don't know if you want to talk a little bit more about trial designs.
Right. So, I could just basically echo what you were saying, is that these were trials that were designed for superiority, which means that all of the assumptions and all of the thought that goes into how you design and how you're going to make a conclusion is based on that difference that you expect to see, which is a vastly different set of assumptions than you would make for a non-inferiority trial, which would then be looking at whether something is just that non-inferiority. It could be superior as well. It would not necessarily be equivalent. And so it's tempting to try to make that kind of a conclusion, but it really is not statistically valid to do that.
And as far as the ITT part of the trial, which was a primary endpoint, that rationale doesn't fall into that.
Yeah, so some of this, and this is some of the comments I would make later when I do some broad strokes, which is that sometimes these decisions have to transcend statistical principles, and it's really based on what we see and what we have to understand to be good for the patient population, and not necessarily just based, on a statistical principle.
I can make an additional comment too. I think, this topic of exploratory subgroups and ITT populations is a good one for further discussion. I think, if a trial fails to meet its primary endpoint in the entire trial population, it's not, you shouldn't really be rescuing that trial with an exploratory subgroup analysis. But if the trial meets its endpoint in the overall trial population, we do look at these key subgroups. We do it in every single approval. We look at key subgroups, not necessarily with a result of restricting the indication as was done in this case, but we really want to be confident that there is a favorable benefit risk assessment for that entire trial population.
I would like to make a small comment here. We have a drug here which induces a modest progression-free survival benefit, no overall survival benefit. In that case, I'm particularly interested in quality of life data. I know the protocol mentions that quality of life has been studied in this trial, so we will see the results. It's just a pity that these data on quality of life come much later and very often are published in second-class journals, while they are really important. And here they could tell us to what extent an oral drug is perceived as something better for patients than an intramuscular injection. So I wait for this data with interest.
Yeah, I have a question related to the PFS. As a potential accelerated approval versus regular approval endpoint. And in this occasion, the PFS benefit was modest. There was no OS benefit at that time point. My question, and I would like to hear FDA's perspective, is that perhaps how we look at PFS can be different depending on the breast cancer subtypes, can be different if we're talking during an endocrine sensitive period versus a chemo period, how late one treats with a particular therapy. So I wanted to just, because there are other drugs that had a similar PFS but may not have gotten a regular approval until there was OS, not in the endocrine sensitive space. So I would like to hear your comments. Thank you.
I think your question is related to how sometimes, for example, same endpoint can actually be used for traditional approval versus in another scenario may be actually used for regular approval. That has been the case, for example, for progression-free survival or response rate In some scenarios, we have used durable response rate for regular or traditional approval. Similarly, for PFS, actually, if there is significant amount of uncertainty about the PFS because of the statistical issues, then we have actually, in rare occasions, have given accelerated approval and have required the sponsor to actually provide additional information as post-marketing requirement to convert that approval to traditional approval. So it's not just about the endpoint per se, it's also about whether we are confident in the results or there is actually a certain amount of uncertainty about the results, then we may have required, additional.
A follow-up here, in terms of, for example, endocrine sensitive disease, hormone receptor positive disease, there are treatments, subsequent treatments, especially now with metastatic setting and HER2, that can confound the OS. You take that into account, and would you take it more in an HR positive than a triple negative? Because traditionally triple negative have been approved on both PFS and OS as a regular approval. And the fact that now, for example, we have in HER2 for the HER2 low, even in triple negative, would that change your approach? Could a drug actually be approved based on PFS? Understandably, there are many, many components that go into consideration.
I think we review each application separately, so we don't actually divide them by HER2 positive, triple negative. But this is a great question, actually, when we meet with the sponsor at essentially at the stage that they're designing their trial, and they want to actually discuss about what approval pathway they're going after. So we give them advice about, like, for example, the primary endpoint, how to design it, and so forth. Yeah. I don't know. I see many, actually. That's great that we have. So maybe first we go to the second microphone.
Okay, thank you. My name is Leslie Glenn, and I am a patient advocate, been living with hormone-positive de novo metastatic breast cancer. So I have been in this exact situation where progression from CDK4 and Faslodex do not have enough ctDNA to find an ESR1 mutation. Also have bone mets only. I have old tissue from 2018. So Elacestrant was not an option for me, so I was put on another therapy. I was put on capecitabine. Now I have progressed with capecitabine. So I would really love the opportunity to see if Elacestrant actually works for me with not an ESR1 mutation with bone-only mets. So my question is, what is the endpoint? Do you have like a number that you need to see for those of us who have taken a SERD for 7 years with the intramuscular injection? What will it take for you to approve that for us who would like to have another option in the SERD drug community? I know that there's another one coming down the line, but also that is being targeted for another mutation, right? It's not for those that may not carry it, so.
We really hope that we have more positive trials and we can approve more drugs. At the time that essentially sponsors design the trial, they usually pick a certain amount of magnitude of benefit that they feel is appropriate, and generally we look at it then compared to the trial's findings in terms of toxicity, and if there is positive benefit risk, then that's a sort of like how we make decisions. It's just in this scenario, I think the control arm really underperformed. So if you look at when we reviewed the entire trial's results, actually, the added essentially the magnitude of benefit in the entire population relative to the added toxicity didn't seem to be a positive benefit risk to, and actually I understand that we really don't think that so there may be a patient that may be benefiting from this, and it's just about how we decide about the indication. So how the doctors actually prescribe it, that's essentially out of our hand. I don't know what else that actually, if anyone else wants to comment. I see actually.
Yes,
You can
I just
actually
wanted
add. Thank
to
you.
echo what Leslie said. I know as a patient advocate, there were many, many patients who were looking forward to the approval of the first oral SERD. And when that approval was done, knowing that it was only for the ESR1 mutated hormone positive population, there are a lot of disappointed patients out there. It's not just having another option, but also you look at the other option, which is fulvestrant, requires an office visit. And not only that, but so you're looking at time toxicity there for patients, whereas they could be taking an oral medication at home without having to make those frequent visits. And they're not fun injections. I mean, they are painful. So I echo her sentiment in that I was very disappointed to see that it was only approved for those who have ESR1 mutations, and really hope that that gets changed in the near future, because in the meantime, the patients that cannot get access to that drug because they don't have an ESR1 mutation may not be alive by the time it is actually approved for everyone with hormone-positive metastatic breast cancer.
I don't know if actually Dr. Sosa from EMA is also on. Maybe he can also add some comments from. We were hoping that we also have someone from Europe, from their
I think he's gonna be
regulatory
on.
agency, connect our panel, but maybe there is an issue with the Zoom. So one thing that I want to say about this trial's results, which although it was statistically significant in the entire population, there were discussions that does this magnitude of benefit in the entire population is actually clinically meaningful. And essentially, when we were discussing, this amount of modest benefit that was seen, essentially because the activity in the control arm was almost like just one scan. Essentially, when you scan a patient until the progression, was just like seeing like, oh, they progressed right after like first the scanning, they were progressing. So it was hard to be confident that the drug is active. So that's why I think the review team really tried to find a group of patients that within this trial that had very modest activity actually benefit the most, to actually be certain about the activity of the drug. So that's one of the issues, I guess. The line of therapy and the way it was actually, the trial was designed, since patients already were on hormonal therapy and CDK4/6 inhibitor for a long time. Really, the fulvestrant and this drug essentially both had very modest activity at the end. So we were not confident about the activity of the drug in the entire population. I see there are actually several other questions on this microphone, please.
Yeah, John Martens, Erasmus Medical Center, biomarker researcher. Liquid biopsies are in some sense challenging, so should we not take into account whether patients have mutations in the blood? Because some people are ctDNA negative, and basically they should be excluded from the trial, if you ask me. So should we in the future not take that into account?
I couldn't quite understand the question. I think the question is asking about...
Having mutations is a prognostic factor. So you compare something. Some patients which don't have mutations are not informative in the trial. So should we not take that into account in trial design using liquid biopsies?
Well, I understand your point. What I am hoping, perhaps, is that we will design trials for these ESR1 mutated patients specifically, because we learned at this conference that they have a very aggressive disease, they have a different behavior, so I wonder if it's not time to really design trials for these patients so that we don't have the problem that was highlighted by a patient with this deep frustration that you cannot access the drug because you are tested negative. So I think it deserves some thinking that perhaps we need to look at this patient population more carefully and design specific trials for them.
I understand the need, so I'm not arguing against that, but I think that there is a prognostic factor in the trial, and you should exclude that.
My name is Naji El Sagir from the American University of Beirut, Lebanon. I love the issue of replacing intramuscular fulvestrant with oral Elacestrant or other SERDs. And following up on the patient advocate, you know, there is a big difference regarding accessibility and price. I understand we think that FDA does not take costs into consideration when they approve drugs. And we all oncologists lobby for accessibility of drugs to everyone. Is there a way that does FDA take into consideration the costs or thinks of doing that in the future?
Actually, at FDA, we don't consider the cost. So we essentially just look at the results without any consideration about the cost.
That's why in the guidelines, you know, when we put out guidelines, sorry for follow-up, is that people take that into consideration. We really need to, we'd love to make sure that drugs become accessible, and reducing the prices become very important there too. Thank you.
Yeah, I think we agree that this is it's a really, really important issue. It's not, you know, it's not in our purview, not by choice, but because of the way the regulations regarding how FDA operates are written.
I see Dr. Sosa actually has joined, but I don't see him on the screen up here. I see him down in our screen. If Dr. Sosa, if you can hear us, we wanted to see how EMA actually decided about the indication for Elacestrant. We understand it is approved in Europe. He is muted on the screen.
And before, I mean, the difference in approval is CDK4/6 inhibitors versus not before. So I wanted to ask the FDA panel. The trial was done with 100% of patients having received a CDK4/6 inhibitor, but in the US, the approval did not mention anything about a CDK4/6 inhibitor.
Yes, so we can actually comment on that until Dr. Sosa.
Yeah, sure. I think that's a great question, and perhaps Dr. Sosa can then comment on practices in Europe. So yes, I think the indication does not specifically mention a CDK4/6 inhibitor, and so FDA thinks pretty carefully about the wording of these indications, and particularly to have some flexibility for the practice of medicine, not in just the specific time in which we're approving the product, but also for the future. So for example, if we were to specifically indicate that this product was following a CDK4/6 inhibitor, unless there's a specific biologic rationale why you have to have received a CDK4/6 inhibitor first for this drug to have activity, in 10 years, if the first-line standard of care treatment changes in the US and we're using something else that's not a CDK4/6 inhibitor, all of a sudden that indication would be completely outdated, and it would be very hard to, then apply that indication to the practice of medicine. Do you have anything to add?
No, and that's essentially why majority of the times we, for example, say after prior systemic therapy or after endocrine regimen without specifying exactly, for example, or after a HER2 regimen, and instead of specifying exactly what drugs were used, because, for example, practice of medicine may change in a couple of years, and we can move on to another question until Dr. Sosa can join us. Please.
Razvan Popescu from Switzerland. I'm slightly confused about the trial design because I don't see this as being a trial between A and B, but as being a trial comparing A to B or C, out of which one is obviously more effective than the other. So we've seen PFS curves looking at the mutational status. We may see, hopefully in future, curves looking at the endocrine sensitivity status, but will we see curves looking at the comparison between drug A and drug C, which would be fulvestrant in my thinking?
Yeah, so I think that's a great question and something we considered during the review. So on this trial, if I remember correctly, about 70% of patients, perhaps slightly more on the control arm, received fulvestrant and the rest received an aromatase inhibitor. And certainly we consider whether there might be heterogeneity of the treatments patients received on the control arm. I think in this trial, it was quite surprising, again, the first trial in an entirely post-CDK4/6 inhibitor setting, that really the PFS on the control arm was quite short regardless of the therapy received, and in most cases, patients were progressing around the time of the first scan, regardless of the therapy received on the control arm.
And there was an analysis comparing fulvestrant to elacestrant on the trial that's been published and showing a superiority of elacestrant, right? In the ESR1 mutated tumors.
Okay, so we're going to move on to the third presentation. It looks like there is still some technical issue with having our EMA panelists join us. But if he can join us, perhaps we will continue that discussion at the panel discussion. Thanks. Dr. Osgood is now going to present the Capivasertib's FDA approval.
Good afternoon. Again, my name is Christy Osgood, and I will be presenting the late-breaking approval for Capivasertib. These are my financial disclosures. Capivasertib was approved on November 16, 2023, in combination with fulvestrant for the treatment of adult patients with hormone receptor-positive, human epidermal growth factor receptor 2 negative, locally advanced, or metastatic breast cancer with one or more PIK3CA, AKT1, PTEN alteration, as detected by an FDA-approved test following progression on at least one endocrine-based regimen in the metastatic setting or recurrence on or within 12 months of completing adjuvant therapy. Capivasertib is administered 400 milligrams twice daily for 4 days, followed by 3 days off, with fulvestrant at the approved and labeled dose. The basis for this approval was the safety and efficacy results from Capitello 291, an ongoing, randomized, placebo-controlled, double-blind, multi-center trial in 708 patients with hormone receptor-positive, HER2-negative, advanced or metastatic breast cancer. All patients were required to have disease progression on an aromatase inhibitor-based therapy in the metastatic setting, or recurrence on or within 12 months of completing neoadjuvant or adjuvant therapy. Patients were allowed to have received up to 2 prior lines of endocrine therapy and up to 1 line of chemotherapy for locally advanced or metastatic disease. Patients were randomized 1-to-1 to receive Capivasertib plus fulvestrant or placebo plus fulvestrant. Randomization was stratified by the presence of liver metastases, prior treatment with a CDK4/6 inhibitor, and geographical region. The dual primary endpoints are progression-free survival, assessed by the investigator according to RECIST version 1.1 in the overall population and in the K3CA, AKT1, PTEN altered, or biomarker positive population. Overall survival in the overall population and the biomarker positive population are key secondary endpoints. Objective response rate and duration of response were also assessed. Eligible alterations were identified in the majority of FFPE tumor specimens using the Foundation 1 CDX next generation sequencing. When a study with a targeted agent, such as Capivasertib, is completed in a population that includes both patients who have the biomarker of interest, as well as patients who are negative for this biomarker, FDA must evaluate whether there is benefit in both the biomarker positive population and in the population that are negative for the biomarker when considering the indication that will be granted. Recently, FDA has been encouraging sponsors to design clinical trials for targeted agents so that the trials are adequately powered to test the primary endpoint, not only in the biomarker positive population, but also in the biomarker negative population. However, in the absence of this, FDA will perform an exploratory subgroup analysis of patients in the biomarker negative population and try to apply the principles laid out in this table to determine the most favorable population in which to take regulatory action. On the left-hand column, we have the factors we assess when evaluating targeted agents. First, there must be a biological rationale, which may include in vivo and in vitro data, as well as a mechanism of action justification to support the use of the investigational agent either in the overall population or in the biomarker positive population. The precision and the prevalence of the proposed biomarker must also be considered. A more precise biomarker that identifies a specific population, such as those identified by NGS-based testing, is more likely to favor an indication in a biomarker positive population, compared to a biomarker that is scored on a continuum with no pre-specified cutoff that may favor an approval in the overall population. The rarer a biomarker is in the proposed the rarer a biomarker is in the proposed population, the more likely a biomarker positive population will be favored. Because if the targeted agent is less active in the biomarker negative population, many more patients will be exposed to this less effective agent. Both the efficacy of the investigational agent in the biomarker negative population, as well as the difference in efficacy between the biomarker positive and negative populations, is assessed, even if the analysis in the biomarker negative population is an exploratory subgroup analysis. If there is minimal efficacy in the biomarker negative subgroup and relatively more efficacy in the biomarker positive subgroup, then it may be determined that the benefit in the overall population is primarily driven by the biomarker positive population, and this would favor granting an indication in the biomarker positive population only. As part of any randomized study, FDA evaluates overall survival. Overall survival is often not the primary endpoint. However, it is evaluated at the time of analysis of the primary endpoint to ensure that there is no potential detriment in any population, even if the entire result is immature. Although randomized studies are not powered to evaluate safety endpoints, the safety profile of the investigational agent is assessed, as the toxicity profile is key to determining whether the benefit attributed to the treatment with the investigational agent in any population is significant enough to outweigh any risks attributed to the treatment. Next, when the benefit of an investigational agent in a subgroup of patients is uncertain, FDA considers how long it may take to determine that a patient is not receiving a benefit and just being exposed to the toxicity of the agent. If the investigational agent is given as monotherapy, this lack of efficacy for an individual patient can be determined easily. However, if the investigational agent is given in combination with an agent with known activity in the indication under study, it may take longer to identify that a patient is not receiving any benefit from the added investigational agent. For example, if the investigational agent is given in combination with an agent known to have a median PFS of a year or more, the patient may not be getting any benefit from the investigational agent, but they will be getting the toxicity. And this may not be known for a year or more. Finally, if available, data external to the trial is also evaluated in order to determine if the favored population should be the overall population or the biomarker positive population. This data may be from a second trial of the investigational agent or data from agents in the same class being studied in the same indication. If this data external to the trial is consistent to results seen in the trial submitted for approval, it supports that the results seen in a biomarker-defined population are less likely due to chance. Capivasertib was approved for patients with metastatic hormone receptor-positive breast cancer with one or more PI3K-CA, AKT1, or PTEN alterations. The PI3K, AKT, mTOR pathway is among the most common activation signals in various cancer types, and this pathway is involved in the regulation of cell proliferation, apoptosis, metabolism, migration, and invasion. In hormone receptor-positive HER2-negative breast cancer, AKT activation is a result of activation of the upstream signaling pathways, mutations of AKT1, loss of PTEN, and mutations in the catalytic subunit of PI3K. Capivasertib is a kinase inhibitor of all three isoforms of AKT, AKT1, AKT2, and AKT3, and inhibits phosphorylation of downstream AKT substrates. In vitro, capivasertib reduces growth of breast cancer cells, including those with relevant PIK3CA or AKT1 mutations, or PTEN alterations. In vivo, capivasertib alone and in combination with fulvestrant inhibited tumor growth of mouse xenograft models, including estrogen receptor-positive breast cancer models, and with alterations in PIK3CA, AKT1, and PTEN. This provides the biologic rationale that capivasertib may be more active in patients whose tumors have alterations. In CAPItello-291, approximately 41% of the patients enrolled had a PIK3CA AKT1 activating alteration, a PTEN loss of function mutation, or a co-occurring PIK3CA PTEN or PIK3CA AKT1 mutation. The mutation breakdown was fairly well balanced between the two arms, although there were slightly more patients whose tumors harbored an alteration in the capivasertib arm. There were 106 patients with unknown mutation results. 14 patients did not have a tissue sample, but the remainder had failures of testing or interpretation of testing. Although CAPItello-291 was only designed to look for a statistical significance in the overall population and the biomarker positive population, FDA performed analysis of PFS, OS, and ORR in all subpopulations, including the patients with tumors that did not have a result for alteration testing. Throughout this presentation, I will present the results in the overall biomarker positive and biomarker negative populations. The patients whose tumors did not have a result from the biomarker testing are a small population, only about 15% of the overall population, and likely a heterogeneous group, so any results must be interpreted with caution, and no conclusions can be drawn. This slide displays the demographics and baseline disease characteristics of patients in CAPItello-291. The majority of the demographics and baseline characteristics were well balanced in all of the populations presented, although there were more premenopausal women in the placebo plus fulvestrant arm in the biomarker negative population. Additionally, and notably, CAPItello-291 did not require prior therapy with a CDK4/6 inhibitor, which is the current standard of care first-line therapy for metastatic hormone receptor-positive HER2-negative breast cancer in the United States. However, approximately 70% of the patients received a CDK4/6 inhibitor prior to being enrolled in CAPItello-291. CAPItello-291 demonstrated a statistically significant improvement in PFS based on investigator assessment in the overall population. The median PFS was 7.2 months in the capivasertib arm compared to 3.6 months in the placebo arm, with a hazard ratio of 0.6 and 95% confidence intervals shown on the slide. Capitello 291 also demonstrated a statistically significant improvement in PFS based on investigator assessment in the biomarker-positive population. The median PFS was 7.3 months in the Capivasertib arm compared to 3.1 months in the placebo arm, with a hazard ratio of 0.5 and the 95% confidence intervals shown on the slide. In the exploratory subgroup analysis of the biomarker-negative population, the median PFS by investigator assessment was 5.3 months in the Capivasertib arm versus 3.7 months in the placebo arm, with a hazard ratio of 0.78. This 6-week difference in median PFS is not felt to be clinically meaningful in this context, given the added symptomatic and serious toxicities seen with the addition of Capivasertib. The PFS results by investigator assessment are further supported by the exploratory analysis of PFS by blinded independent central review. In the biomarker-positive population, the median PFS was 7.3 months in the Capivasertib arm compared to 3.3 months in the placebo arm, with a hazard ratio of 0.5. This PFS improvement was found to be robust to subgroup and sensitivity analysis. In the biomarker-negative population, the median PFS difference by BICR is approximately 5 days, with a median PFS of 3.9 months in the Capivasertib arm and a median PFS of 3.7 months in the placebo arm, with a hazard ratio of 0.81. This supports the potential lack of clinical meaningfulness observed in the PFS by investigator assessment. Given the PFS results by both investigator and BICR, FDA determined that the results in the biomarker-positive population primarily drove the statistically significant PFS result in the overall population. The observed overall response rate, objective response rate, in the biomarker-negative population was 17% in the Capivasertib arm and 14% in the placebo arm, with overlapping confidence intervals. On the other hand, in the biomarker-positive population, the observed objective response rate was 29% in the Capivasertib arm compared to 10% in the placebo arm, which supports that there is substantially higher activity seen with Capivasertib in the biomarker-positive population. In an interim OS analysis, which occurred at 40% of the required events for the planned final OS analysis, the hazard ratio in the biomarker-negative population was 0.9, with 95% confidence intervals shown on the slide. Also shown on the slide, the KM curves in the biomarker-negative population crossed multiple times, making any interpretation uncertain. On the other hand, the interim analysis of OS in the biomarker-positive population had a hazard ratio of 0.69, with the KM curves for the Capivasertib arm and the placebo arm demonstrating separation throughout the assessment period. The safety profile of Capivasertib in combination with fulvestrant showed substantially increased toxicity over fulvestrant monotherapy. The overall population formed the basis of the warnings and precautions data in the prescribing information for Capivasertib. FDA separately assessed safety in the biomarker-positive and biomarker-negative populations. Patients in all 3 of these populations treated with Capivasertib plus fulvestrant experienced more greater than grade 3 adverse reactions, more adverse reactions leading to dose interruptions, dose reductions, and discontinuations. The safety signals included in warnings and precautions section of the label are hyperglycemia, diarrhea, and cutaneous adverse reactions. Hyperglycemia occurred in 20% of patients treated with Capivasertib and occurred in grade 3 or 4 events occurred in 2.8% of patients. This included diabetic ketoacidosis and diabetic metabolic decompensation. Additionally, in the 65 patients who experienced hyperglycemia, 45% required treatment with anti-hyperglycemic medications, including insulin and metformin. Diarrhea is the most common adverse event in Capitello 291, occurring in 72% of patients in the safety population treated with Capivasertib.
Dose interruptions for capivasertib occurred in 14% of patients, and dose reductions occurred in 11% of patients, while 2.7% of patients discontinued capivasertib due to diarrhea. The PRO CT-CAE assessments from Capitello 291 showed that diarrhea added to the quality of life burden for patients treated with capivasertib. Finally, cutaneous adverse reactions are another important safety signal of capivasertib. These occurred in 58% of patients in the safety population, including 19% who experienced a grade 3/4 adverse event. 17%. The most serious cutaneous adverse reactions included erythema multiforme and drug reactions with eosinophilia and systemic symptoms or DRESS. Dose reduction was required in 7% of patients, and 7% of patients permanently discontinued capivasertib due to cutaneous adverse reactions. As Dr. Shah introduced in the prior presentation, two types of randomized trials are replacement and add-on designs. Capitello 291 was an add-on design. In an add-on design, both arms contain a backbone with a known amount of activity in the disease under study, and the drug under investigation is added to the experimental arm. Therefore, the improvement in the primary endpoint must be large enough to outweigh any added toxicity observed. In Capitello 291, the performance of the placebo plus fulvestrant was modest with respect to PFS, and the median PFS improvement in the capivasertib arm in the overall population was felt to be marginal, particularly in the context of the additional symptomatic and serious toxicities. While the risk-benefit was not felt to be favorable in the overall population, the efficacy in the overall population appeared to be primarily attributed to the biomarker-positive population, and the magnitude of PFS improvement in the biomarker-defined population was felt to be favorable and to outweigh the added toxicities. The FACTION study, a phase 1b/2 double-blind, placebo-controlled parallel group, randomized multi-center study of capivasertib plus fulvestrant versus fulvestrant alone in postmenopausal women with advanced breast cancer, previously treated with an aromatase inhibitor, was submitted by the applicant as supportive data external to the Capitello 291 study. Although the study was small and activity estimating and hypothesis generating only, an updated analysis of the FACTION study from 2022 supported that capivasertib appears to have greater activity in the biomarker-positive population than in the biomarker-negative population. This finding of potentially less activity in the biomarker-negative population, which is consistent with the mechanism of action of capivasertib, makes the finding of Capitello 291 to be less likely to be due to chance alone. After reviewing the data submitted to support the capivasertib application, FDA used the algorithm provided by this table to make a determination to approve capivasertib in the biomarker-positive population only. There were 3 factors that did not favor either the overall population or the biomarker-positive population. The prevalence of the biomarker was about 40 to 50% of patients. The overall survival results were immature in all populations and had to be interpreted in caution in the biomarker-negative population, but did not show a detriment in any of the populations. And the ability to quickly identify the lack of efficacy did not favor either the overall or the biomarker-positive population. Since Capitello 291 used fulvestrant, which is only a modestly active in the second-line treatment of patients with metastatic hormone receptor-positive, HER2-negative breast cancer, the lack of efficacy cannot be determined as easily if it was given as monotherapy. However, can still be determined more easily than if capivasertib was paired with an agent with more robust activity. Therefore, this category did not favor either. The remainder of the factors supported approval in the biomarker-positive population. First, the biologic rationale that capivasertib is a pan-AKT inhibitor that targets all 3 isoforms of AKT, and the PI3K, AKT, mTOR pathway is often mutated in breast cancer, leading to anti-apoptosis, angiogenesis, and metastases. Targeting AKT in those with mutations of this pathway should reduce tumor growth and the chance of metastases. In the case of Capivasertib, the biomarker is an NGS test for specific mutation and has been well validated. The 6 weeks difference in median PFS in the biomarker negative population is not felt to be clinically meaningful and was smaller than the 4.2-month PFS difference observed in the biomarker positive population that was robust to subgroup and sensitivity analysis and felt to be clinically meaningful. The safety profile demonstrated that both patients in the biomarker positive and biomarker negative populations treated with Capivasertib plus fulvestrant experienced more toxicity. The marginal improvement in median PFS in the overall population and the biomarker negative population does not justify the added toxicity of Capivasertib. Additionally, public results from the external faction study suggests that Capivasertib may have greater activity in the biomarker positive population, which is also consistent with the mechanism of action. Based on all of this information, the risk-benefit was not felt to be favorable in the overall population, and the efficacy in the overall population appeared to be primarily attributed to the biomarker-positive population. And therefore, FDA granted regular approval for Capivasertib in combination with fulvestrant for the treatment of adult patients with HR-positive, HER2-negative, locally advanced or metastatic breast cancer. Also, on November 16th, FDA provided a contemporaneous pre-market approval for the Foundation 1 CDX. I would like to thank all of the people on the slide, San Antonio Breast Cancer Conference for inviting me to speak, and especially the patients and their families who contributed to the results of this trial.
Thanks. Now we can take questions from audience. Yes, please.
Thank you. I'm Ann Fonfa. I run patient advocate group Anti-Appleseed Project. Our focus has always been on the many harms of treatment. All of these trials demonstrate expected harms. Isn't there anything that you can come up with that will reverse or protect or prevent the people in the trials and in the clinical population from suffering these? Our focus has been to gather the many studies on non-level 1, because of the cost, on natural substances and ideas, and many of them have efficacy and effectiveness, and people are suffering. And that's not to discuss the unexpected toxicities that are occurring. Thank you.
Hi, I think that's a wonderful statement, and the FDA definitely agrees with you that we would like to have, be able to provide therapies with fewer toxicities, as well as provide therapies where the toxicities could be prevented. At this point in time, we are, held to the studies that come in, and being able to inform providers and patients of the expected toxicities, as well as collect information about any unexpected toxicities in hopes of protecting the American people and the patients that will be receiving these agents.
One of the projects that actually at FDA has started, Project Optimus, maybe Dr. Shah can discuss that, about those optimization that should happen early on to hopefully reduce the toxicities from the drugs.
Sure, I'm happy to discuss FDA Oncology Center of Excellence's Project Optimus. So for too long, cancer products have been dosed, or the dosages have been developed according to a maximum tolerated dosage. We've inherited this practice from the development of chemotherapy agents, but is also often applied to our current oncology products, which include many targeted therapies like the products that we have discussed in this session today. The goal of Project Optimus is really to reform this dosing paradigm in oncology and really consider the safety and tolerability tolerability of these products when the dosages are being decided, and to better characterize the dosages to arrive at a dosage that better balances benefit risk of these products, and to do this early in the pre-market setting so that at the time of approval the dosage has been optimized for efficacy but as well as safety and tolerability to ideally arrive at a better tolerated dosage for future products. I don't know if Janice Cowden would also like to comment.
Sure, thank you. I think, we are very excited to know that FDA is looking at a range of doses and moving away from MTD, looking at maximum efficacy. But I think one of the things that, we would love to see is in early phase and phase 1 trials is not just looking at safety and tolerability, but looking at efficacy as well, so that we can have a better understanding of not only the side effects from these drugs early on and what an optimal dose is, but if there is a lower dose that has efficacy with fewer toxicities, then we should know that.
Yeah, I totally agree with that, and I think that's the goal, to better characterize different options for dosages early, to really take forward the one or ones with the best benefit risk in terms of efficacy and safety and tolerability.
Because we have a chance now to have Dr. Sosa from Europe with us, I would like to ask him if EMA is also likely to grant approval for the biomarker-positive subpopulations concerning Elacestrant and Capivasertib. Are you going to go in the same direction compared to FDA?
Hello, my name is Aaron Sosa. I am Denmark's alternate member at the CHMP, and I am very happy to have been invited to represent the European Medicines Agency in this panel discussion for new approvals. So regarding Capivasertib, out of the 3 products that have been discussed, we have also approved Enhertu in the HER2 indication, and also Orserdu as Elacestrant in a very similar indication. Regarding Capivasertib, it is the one product that is still ongoing, and although I cannot disclose the very specific details, it is very likely that we will follow and align the indication on a biomarker-positive population. But this still needs further discussion, and it is likely we will have a final opinion in the next few months.
Thanks, Dr. Sosa. We're now going to microphone one.
All right. Thank you. My name is Michelle Tregear, and I'm with the National Breast Cancer Coalition. And I guess my question is, I'd like to understand why we continue to allow biomarker-negative participants into biomarker-driven drug trials. I think we often see in earlier stage phases of trials where we're including these biomarker-negative groups that they're not active and they're not as effective, and yet we continue to enroll them. And this seems to me to be putting patients unknowingly at risk. And it also seems to fly in the face of precision medicine. And I know while there was no OS detriment here in the analysis that the FDA did in the biomarker-negative trial or group, we know that there are many examples where that's not the case. There is OS detriment. And so I guess this is really a question probably more for trial sponsors, but I'd really like to start seeing precision medicine in precision patients.
I'll start, and then I think Flora Mulkey, the statistician, has something to add. We agree with you. This is why recently the FDA has been providing advice to sponsors to specifically look at the biomarker-negative population so that we can make this determination if there is a detriment. And in doing so, we are also asking them to provide a biologic rationale or a justification for including these patients in the clinical trials, so hopefully we can get the right drug to the right patient at the right time.
Right, this is Flora Mulkey, yes. I just wanted to add that FDA does have a guidance for industry on developing targeted therapies, and we do encourage sponsors to conduct trials in enriched populations if they have the ability to do so. And it does state that we, if in the absence of that, what we ask is that sponsors provide an indication of what would be a clinically meaningful improvement in primary and key secondary endpoints for that population, so that we can, establish that that beneficial treatment is applicable to the overall population. And so that is, we agree that it is an important point, and we do have guidances there for sponsors to review.
Just a quick comment. I support the statement, but there is one caution, and this is heterogeneity of the marker expression across metastatic sites. So that's something that we know today. It's particularly true for HER2. So you can biopsy one metastatic site, it will come back negative, but the metastasis just not far away could be positive. So that is a complication factor that we need to keep in mind. And unfortunately, there are very few trials that incorporate molecular imaging as a way to better assess who benefits and who doesn't benefit from these targeted drugs.
I think the other point, especially when discussing Capivasertib, is the fact that on the trial, we were looking at mutations in the AKT pathway genes, but there's a lot of other ways to look at the AKT pathway that has nothing to do with mutations. And you can have an increase in expression of the pathway. And so the thought is that many of these patients may benefit, and there's going to be more data being presented, potentially looking at that may not have mutations in the pathway, but may have an overexpression in that pathway, and then inhibiting that pathway with Capi may actually work. So I think we just don't have the whole picture. And withholding treatments from patients that may potentially benefit is also a concern.
Next microphone, please.
Hi, thanks. My name is Jess Hogue. I'm a biostatistician with Exact Sciences. And my question kind of follows on the previous and digs a little deeper. I mean, is FDA considered recommending or requiring a formal statistical interaction test between treatment and biomarker status in association with outcome, or is it really just a sample size limitation in the metastatic setting?
I think it's situational dependent, but we do sometimes look at interaction tests, but we don't always require that, and a lot of times I don't know that we recommend it per se. That doesn't mean we don't review that when we're analyzing the data as it comes in. But we have encouraged actually powering for the negative population. Just sometimes there's pushback on that.
So I think, as we learn, obviously, at the time that the trial may be designed, they may not know the drug works in certain population, for example, so they may not even plan to stratify by biomarker, but if there is some information that a biomarker is important, then essentially we recommend that they stratify, and also if there is a possibility that the drug may have differential activity in a certain biomarker, then we actually ask them to look at the results separately in two cohorts. So to have at least some minimum sort of requirement for what would be considered clinically meaningful in terms of winning in the biomarker negative. But sometimes, at the time that the sponsor designs the trial, they have only treated few patients and they saw some overlapping responses. For example, they didn't know that the drug actually works better, a lot better in the other, for example, biomarker positive patient population. This microphone one.
Hi, I'm Elisa Chandler. I'm an advocate from the NBC Alliance. And I wanted to follow up on Janice's point as well, that I applaud the FDA for this optimist effort to look at the minimum effective dose. And I'm just wondering, I don't really know much about it, whether there's going to be some sort of a threshold of, data points or regarding side effects, and looking at whether drugs that have already been approved, like Capi, are you going to do a look back, and is there going to be any kind of threshold for when you're going to really review drugs for the minimum effective dose until such a point that it's permanently adopted?
Hi, thanks for the question, and I think it's a great one. So something that we're encouraging through Project Optimus is the use of, not looking at safety and tolerability and some of the more conventional measures, but also integration of patient-reported outcomes earlier in drug development. And this is really to capture a fuller picture of what might be a patient's experience taking the drug, and particularly, all of our presentations mentioned some higher grade toxicities, but also things like diarrhea or nausea or vomiting that might be only captured as low grade in the context of conventional safety metrics, but extremely bothersome to be experiencing every day. So something that we are really encouraging with these dosage optimization efforts is using these PROs, getting a fuller picture of the tolerability of the product, and using that information as part of the totality of data when companies are deciding which drug dosage or dosages to move forward. Regarding capecitabine, great question, and I think my colleague, Dr. Christy Osgood, wanted to address that.
I think that you were asking about the dose in Capivasertib, and I can also add does it capecitabine, or was it? I think so. We did look at the dose that they proposed initially when they came in as part of the application, and our colleagues in the clinical pharmacology group looked very closely to see, given the high levels of toxicity that were observed, whether there was a dose that might be able to be investigated to see if it was as efficacious with less toxicity. However, unfortunately, we did actually have quite a bit of dosing data on Capivasertib, and so there is not another dose to investigate at the present time, and that was not part of the requirement during the approval. But a lot of work was looked into because, particularly with the diarrhea side effect having so much impact on burden in patients, we wanted to try to find a more tolerable dose.
Thank you. Next, please go ahead.
Okay. So the question is the alteration of the axis BI3K, AKT B10. We know that this is half of it because the most important part is hypoxia-inducible factor 1, which is come after the AKT, and then there is nuclear F kappa B, which is the one that leading to the issue of the hypoxia. Now in this trial, they concentrate on BI3K, AKT, and B10 loss or alteration, and they give number. We know that the AKT, this percentage is very small in humans, which is about 3%, and also the AKT, so the B10 also, it is about 5%. But they never mention about the vascular endothelial growth factor, the hypoxia-inducible factor, the nuclear kappa, the beta-catenin. Nothing has been mentioned at all in this because, however, this is the pathway that it should be, look at it from number one, from A to Z. Now, the second question is where it will be alpelisib fit for the BI3K patient. So we give this medication, or we are going to give alpelisib. Which one? So what is how we are going to sequence?
Yes, thank you so much for your question.
For what? For the question number 1 or number 2?
For both of them.
Okay.
For both of them, and I will try to address them to the best of my ability. So, I think as far as looking at other molecules in the AKT pathway, I agree with you. I think that we do need to look at those and potentially also see if these drugs are active in patients who have mutations in those pathways as well. However, that was not done in the clinical trial, and so we have to base what our indication based on what was studied in the clinical trial, but we could encourage other investigators to look at these questions. As far as your second question about alpelisib, as far as patients with PI3K mutations, the companion diagnostics are slightly different and look at slightly different mutations, although some of them are overlapping. And I think at this point in time, it will be a clinical decision for providers to determine which agent they wish to use first or second if the alterations are overlapping, and that may be based on the side effect profile, patient preference. Additionally, I don't know what will happen in the future as far as sequencing Capivasertib and alpelisib, because they are currently indicated in the same patient, in the same line of therapy.
And just to add, that's why we encourage discussion also with our colleagues in CDRH about these issues early in device and drug development, because the more information we have with this, the better we can make those regulatory decisions.
I think there are two very critical issues for oncologists sitting in this room. The number one issue is going to be access to these drugs, because they are going to be expensive and there must be some kind of prioritization. So, for example, in my country, alpelisib has not been approved for reimbursement because there was no overall survival benefit and quite a lot of toxicity and a high discontinuation rate. It looks like Capivasertib has a lower discontinuation rate, but this could be due to the fact that we learn better how to handle the side effects, perhaps. But access will be a big problem, and at least I'm hoping that the ESMO magnitude of clinical benefit scale that was developed inside ESMO will help with this prioritization. And you know that the scale gives a lot of importance to overall survival and quality of life, and not so much on progression-free survival. But the second issue was raised by one of you, and it's the optimal sequencing of these drugs. We have more and more drugs, which is excellent news for our patients, but we know nothing about their sequencing. And I wonder who is going to finance these trials, looking at the optimal sequence. I don't even know if pharmaceutical industry will help us solving these questions, but they are really important for the doctors, but also certainly for the patients.
Thank you. Please, go ahead.
Thank you. I'm Farah Brasfield from Kaiser Permanente in California. My question is regarding the issue that in real-world clinical oncologists deal with, having to decrease dose for toxicities and then having to rely on post-marketing studies on pharmacokinetics of the drugs, a lot of them on immunotherapy or some of the biological therapies, to see whether at lower doses the efficacy of the drug is there, at least based on pharmacy studies. One, should we trust that? And two, can I put a pitch in for FDA to require the drug companies, when they are designing the studies, to actually include multiple dosages rather than the highest dose, the medium dose, and the lowest dose? Thank you.
Thanks very much for your comments, and really they're music to my ears. So this is the intention of Project Optimus and just broad efforts across FDA oncology, is really that these dosages be characterized early and there is collection of more efficacy, safety, and tolerability data in a clinical trial setting that's more controlled. And so, so that these questions aren't deferred to the post-marketing setting, but also so that patients don't have to necessarily experience a toxicity to get the dosage that we actually think is better tolerated and preserves benefit, so that could be evaluated up front, and at the time of approval, patients have the option of getting that dosage, that one with the better balance between benefit risk. And thank you so much for your comments.
May I ask one last question? Part of the trial was a cohort of Chinese patients. Did the FDA take that into account? Is that something, when we talk about different regions of the world, that you guys have some rule for against?
We did take that into account. We did receive, so we received that data separately from the initial submission because those patients started enrolling later in the trial. And we did look at that data very closely. It was a fairly small cohort of patients, and it had different baseline disease characteristics as well as prior therapies. I think in particular, there were fewer patients who received prior CDK4/6 inhibitors. So we did look at that data, and found it to be very difficult to interpret and analyze. But we did look at it and analyze it as part of our review. And we don't have a rule. We in fact encourage sponsors to conduct multi-regional trials and submit data from different regions so that we can get the best sense of how a drug works in multiple different patient populations.
Thank you. The last question I want to ask Ms. Cowden, actually, so we heard a lot about when we, review the applications, we review the efficacy, and then we look at the toxicity, tolerability. In your, view, how do you think about efficacy, the endpoints, and, relative to the tolerability? And obviously, some of these medications are given for longer duration, some are less, some are taken daily, so patient has to deal with them on a daily basis versus one is given at an interval. So those considerations.
Thank you. That's a great question. I think, the endpoints are important to us as patients, progression-free survival and overall survival. The toxicities, which impact our quality of life, probably supersede the PFS and OS data that we see. I think putting us all under one umbrella in a one-size-fits-all type dosing is something that we really need to change and move towards a more patient-centered dosing. As far as PFS, when it is modest compared to what is already approved for standard of care, I think the focus there for patients is usually which one is going to be more tolerable. Mm-hmm. It's not a matter of 2 months PFS. Really, even the data that may be coming out and saying it's clinically meaningful or statistically significant, 2 months is not a great deal of time. So I think we have to look at the tolerability of the drugs, and really it's only the patients who can say whether something's tolerable. And the side effects, if we're looking at like Capivasertib, if you're looking at grade 3 or higher diarrhea, I don't know anybody that could have a decent quality of life. Even grade 1 or 2 has a negative impact on quality of life. So I think we really need to focus on quality of life in these trials, look at phase 4 studies, and have patients there from the very beginning for trial design all the way through to the end, get patient advocates involved.
I appreciate it. I want to thank all of you guys. Actually you come here and you gave your time, and we had some calls. I really appreciate you coming in and all of the really interesting and thoughtful questions that we received. We continue to learn from you all, so thank you. And this was really an honor and pleasure to be with you all. Thank you. Bye.
Thank you.